Welcome to a new deep dive. Today we're tackling a request from a listener, someone needing to get up to speed and quickly on some key concepts in obstetrics and gynecology.
Yeah, well, I've got this source material. It's a concise review, really geared towards, boosting scores on medical exams,
Yeah.
backed with factoids.
Exactly. So our mission here is to pull out the most crucial, the most insightful bits from this, well, pretty dense material. Make it easy to understand and hopefully really memorable for you.
We'll be hitting quite a range. Breast conditions, menstrual issues.
Pregnancy complications, gynecological conditions, the whole spectrum, really.
Right, let's dive in.
Okay, so starting with breast issues, what jumps out first?
Well, the review is quite good at highlighting subtle differences, like distinguishing mastitis from a breast abscess.
Okay.
It points out a non-fluctuant mass often means mastitis, whereas a fluctuant one suggests an abscess.
Fluctuant meaning like movable fluid inside.
Exactly. That suggests a collection of pus,
Yeah.
right, which defines the abscess. And that distinction is really critical.
Why is that? Treatment difference.
Big difference. For mastitis, you often continue breastfeeding, use antibiotics. But an abscess, that usually needs drainage before the antibiotics can properly work.
Right, get rid of the source. That really shows the importance of the physical exam, doesn't it?
Absolutely. Hands-on assessment is key.
So speaking of things that might feel similar, what about a galactocele?
Good point. That can also be a tender mass, maybe even feel a bit fluctuant like an abscess.
Okay.
But the key difference, the review notes, is timing and location. It usually pops up in the lateral breast after someone stops breastfeeding.
Ah, the history again. And the treatment.
Much simpler. Often just warm compresses do the trick.
Interesting how the patient's story gives you so many clues.
Definitely. Which ties into breast engorgement, too.
How so?
Well, the review mentions this happening in mothers who are bottle feeding maybe a few days postpartum.
Uh-huh.
And what might surprise you is that this engorgement can actually cause a bit of a fever, maybe even mild dysuria, discomfort urinating.
But it's not a UTI.
Exactly. The urinalysis comes back normal. It's a good reminder, not every postpartum fever is an infection. Sometimes it's just the body adjusting.
That's a really helpful clinical pearl. So fever and urinary symptoms don't automatically equal UTI postpartum.
Got it. Now, the review also mentioned fat necrosis.
Right. This one's kind of fascinating. It can be linked to something as simple as, say, a very tight sports bra or even minor breast trauma.
Really?
Yeah. And the interesting part is down the road, these areas of damaged fat can actually calcify.
Wow. So everyday things can lead to these changes.
Okay, what about benign growths? Fibroadenomas.
Uh-huh. Classic description. Rubbery, mobile, usually painless mass.
And diagnosis.
Typically starts with ultrasound, especially if you're under 30. Over 30, maybe ultrasound plus or minus a mammogram. And if needed, the next step is often a fine needle aspiration, FNA, to look at the cells.
Definitive treatment being?
Excision, surgical removal, according to the review.
Okay. And for general screening, mammograms.
The standard guidelines mentioned are starting at age 50, then typically every 2 years until 75.
Good to know those timeframes. Now, fibrocystic changes. This sounds like a broad category.
It really is, and it presents differently in different people.
How so?
Well, one person might just have a painless cyst on one side. Maybe it drains some brown fluid. Another might have sharp pain, often in the outer quadrant, but maybe no distinct lump you can feel.
And under the microscope, any characteristic features?
Yeah, the review mentions things like sclerosing adenosis, these things called blue dome cysts, and apocrine metaplasia, just histological features.
And management for these generally benign changes.
Usually supportive. Things like evening primrose oil, maybe warm baths for comfort, managing symptoms, basically.
Right. But what if a cyst looks complex on ultrasound? Does that change things?
Yes, that raises the question of needing to rule out something more serious.
So what's the next step then?
Typically, you try to aspirate it, drain it with a needle. But if the mass is still there after aspiration,
Then you biopsy.
then a biopsy is usually necessary, yeah, to get a definitive answer.
Okay. Shifting to nipple discharge. What if it's, say, rusty colored and just from one side?
The review flags that. Unilateral rusty discharge. You should think intraductal papilloma first until proven otherwise. That's a small, benign growth in a duct.
But it could be something else.
It could. If a biopsy of tissue related to that discharge shows a sort of star-like pattern, a stellate morphology,
That's bad.
that's a characteristic finding for invasive ductal carcinoma, a type of breast cancer.
Wow. Subtle visual clues making a big difference. What about DCIS? Ductal carcinoma in situ.
Right. DCIS often doesn't present as a lump you can feel. It's frequently a finding on a mammogram.
What does it look like?
Clustered microcalcifications, tiny calcium deposits grouped together.
And management.
That usually requires a needle-guided open biopsy to confirm the diagnosis.
Okay. And one last one from this section, mammary ductal ectasia.
Ah, yes. That's more about a blocked or inflamed duct. Can present with an inverted nipple and maybe a greenish discharge.
Interesting. So quite a range of presentations for breast issues.
Definitely. And you see how history, exam, imaging, and sometimes biopsy all fit together to guide management.
Absolutely. Shall we move on to menstrual and ovulatory issues now?
Let's do it.
Okay, Asherman syndrome, uterine scarring, right?
Exactly. Uterine synechia is the other term. The review specifically links it to having had a DNC procedure.
Especially after certain events.
Right, particularly after postpartum hemorrhage or maybe a complicated miscarriage involving infection like endometritis,
And a key diagnostic sign.
is the progestin withdrawal test.
Yeah.
If you do that test, the woman has no bleeding afterwards.
Can you explain that test a bit more? What does the bleeding or lack of it tell us?
Sure, so if a woman takes progestin and then stops, and she does bleed,
Uh-huh.
it generally means her body is making estrogen, but she's probably not ovulating regularly. The progestin withdrawal triggers the bleed.
Okay.
But if she doesn't bleed, it suggests one of two main things. Either her estrogen levels are really low, or there's a problem with the uterus itself, like the scarring in Asherman's, that prevents bleeding.
I see. And if it is low estrogen, say in a younger woman with no withdrawal bleed, what are the long-term risks?
Osteoporosis is a big one. Weakening of the bones down the line if that low estrogen isn't addressed.
Really highlights why understanding these hormonal signals is so important.
Absolutely. And speaking of hormonal signals, the review mentions basal body temperature.
Right, the temperature shift mid-cycle.
Exactly. That slight increase indicates that ovulation has likely happened and the ovary is now producing progesterone, a simple but useful marker for tracking ovulation.
Good old-fashioned tracking. Now, circling back to bone health and osteoporosis risk,
Uh-huh.
the review stresses that weight-bearing exercise is key, maybe even more so than just calcium and vitamin D supplements alone.
That's right. Things like walking, where your bones support your weight. It really makes a difference, even for older adults who already have osteoporosis. Regular walks are beneficial.
Lifestyle factors making a real impact. The review also had an interesting example about risk factors.
Ah, the 69-year-old woman profile.
Yeah, Caucasian, nulliparous, on a beta blocker, drinks daily, has a compression fracture. Lots of factors.
But the review singles out one as the strongest risk factor in that specific scenario.
Which was?
Her race, being Caucasian.
That's quite striking. Really shows the influence of genetics and ethnicity.
It does. Now, for women dealing with severe pelvic pain and heavy, regular periods who don't want more children,
And maybe their partner's getting a vasectomy.
right. In that situation, the review suggests endometrial ablation as a potential next step,
Which is.
a procedure to destroy the uterine lining to reduce or stop bleeding. Less invasive than a hysterectomy for the right person.
Okay. Now, shifting to adolescence and puberty, Tanner stages.
Yep, they give us a framework. The review notes that menarche, the first period, is usually imminent around Tanner stage 3 for both breast and pubic hair development.
And if a 13-year-old is only at Tanner stage 2, no period yet.
Then typically just follow up in about 6 months to see how things are progressing.
Got it. And what about benign virginal breast hypertrophy? Sounds alarming.
It can seem that way. It's basically an overgrowth of breast tissue in adolescence.
So if you find a mobile, slightly tender mass in a teen, not sexually active, even with a family history of breast cancer.
The review suggests that often just following up in 6 months is appropriate. It can be a normal response to hormones.
Okay, distinguishing normal development from something needing investigation. Makes sense.
Exactly. Ready to tackle pregnancy complications.
Let's do it. Pregnancy, wonderful, but definitely can have challenges, starting with nausea and vomiting.
Right, the classic morning sickness. The review is reassuring here. If the weight loss is mild, it usually doesn't significantly harm the fetus.
But when it gets severe, hyperemesis carbonarum or HG.
Then it's a different story. A key diagnostic clue is finding ketones in the urine.
Because the body's breaking down fat for energy.
Precisely. Due to dehydration and lack of intake. And HG usually kicks in around 8 to 10 weeks, which is when beta-HCG levels peak.
And biochemically, what changes might you see?
Typically low potassium, hypokalemia, low chloride hypochloremia, and metabolic alkalosis.
Treatment involves hospitalization.
Often, yes. 5E fluids, parenteral antiemetics to control the vomiting and restore balance.
Okay. And interestingly, the review mentions metoclopramide, a non-antipsychotic drug, can cause hyperprolactinemia.
Yeah, it's a D2 antagonist. Good to keep in mind when considering meds.
All right, shifting to fetal growth. IUGR intrauterine growth restriction. What's a major lifestyle factor?
Smoking is highlighted as the most contributory one. It decreases placental blood flow.
And the bad tool to diagnose it.
Doppler ultrasound of the umbilical artery is mentioned as the best diagnostic tool. It lets us assess blood flow.
And which fetal measurement is most sensitive for IUGR?
The abdominal circumference. It's often the first thing affected when nutrition is compromised.
Okay. The review also touches on the difficult topic of fetal demise, especially with clotting disorders like factor V Leiden.
Yes, in that situation, if fetal demise occurs, the clot is most likely to have formed in the uteral placental artery, disrupting blood supply.
Right. Moving to high blood pressure issues, preeclampsia.
Classic definition. New onset hypertension and proteinuria after 20 weeks gestation. The underlying cause is thought to be placental dysfunction, or uteroplacental insufficiency.
But what if you see hypertension and proteinuria before 20 weeks and the uterus seems large?
That raises suspicion for a hydatidiform mole, that abnormal growth we discussed. Moles can cause those symptoms earlier.
Okay, crucial distinction. Now, fetal heart rate monitoring. Those patterns, late decelerations.
D-cells indicate uteroplacental insufficiency, basically. The baby isn't getting enough oxygen. Fetal hypoxia risk,
Early decelerations.
usually benign, means fetal head compression during contractions.
And variable decelerations.
Those suggest umbilical cord compression. They look abrupt and variable in timing.
What about variability, the beat-to-beat changes?
Also important, zero variability with a normal rate, like Warren 20, might just be fetal sleep.
But zero variability with a high rate, say 180.
That's more concerning. Could be maternal fever or fetal distress.
And accelerations, increases in heart rate.
Those are good. Reassuring signs of fetal well-being.
For a bigger picture, there's the biophysical profile, right?
Yes, the BKP looks at 5 things: heart rate, breathing, movement, tone, and amniotic fluid volume. A comprehensive check.
So if you see variable D cells during labor, say at 4-centimeter dilation, 41 weeks, what can be done?
The review suggests amnioinfusion as a management option, putting fluid back in to cushion the cord.
And if the baby's breached late in pregnancy?
After 36 weeks, you might try an external cephalic version, trying to turn the baby head down from the outside.
And an internal pedalic version?
That's different. Used during a breech delivery itself, maybe for the second twin.
Okay. After birth, neonatal scalp issues, swelling that crosses suture lines.
That's caput succedaneum. Usually just edema, temporary.
And if it doesn't cross suture lines, well-defined.
That's more likely a cephalohematoma, a collection of blood under the periosteum. Takes longer to resolve.
Got it. Third trimester skin issues. PUPPP.
Pruritic urticarial papules and plaques of pregnancy. Itchy, hive-like bumps, often starting with the stretch marks on the abdomen.
Great.
Emollients, maybe topical steroids for the itching, usually goes away after delivery.
What about itching on palms and soles?
ICP?
Intrahepatic cholestasis of pregnancy. Yes, intense itching, often palms and soles, but can be generalized. Diagnosed by elevated serum bile acids.
And this one has risks, right?
It does. Increased risk of third trimester stillbirth. So treatment is ursodeoxycholic acid, and often delivery is considered around 35 to 37 weeks.
Okay, important to distinguish that from acute fatty liver of pregnancy.
Very important. Acute fatty liver also presents third trimester, often with nausea, vomiting, jaundice, but with really high bilirubin and LFTs.
Cause?
Deficiency of an enzyme long-chain 3-hydroxycyl-CoA dehydrogenase. Requires immediate hospital admission, consults, IV hydration, and delivery. Serious stuff. Then there's gestational pemphigoid, formerly herpes gestationis.
Right, an autoimmune thing. Intensely itchy rash, often starts around the umbilicus, spreads outward, usually second or third trimester, treated with topical steroids.
And a key point the review makes, pregnancy can happen before the first period.
Crucial reminder. Young teen, nausea, vomiting, suprapubic fullness, no periods yet. Check a beta HCG.
Absolutely. Preeclampsia treatment recap.
Antihypertensives, like labetalol or methyldopa, to manage blood pressure. But definitive treatment is delivery.
And eclampsia, the seizure complication.
Magnesium sulfate is first line for the seizures. Again, delivery is the definitive cure.
What about hypertensive emergencies in pregnancy?
Hydralazine can be used for rapid blood pressure lowering.
Okay. And the pullutein cysts.
Benign ovarian cysts, often bilateral, seen in early pregnancy, usually regress on their own. More common with high beta HCG levels, like in twins or molar pregnancy.
Speaking of moles, complete versus partial. Key differences.
Karyotype, 46 versus 69 chromosomes, ultrasound appearance, classic snowstorm or grape-like clusters in complete versus fetal parts and partial, and the risk of choriocarcinoma is higher with complete moles. That covers a lot of the pregnancy complications highlighted. Ready for general gynecology?
Yep, let's move into gynecological conditions. PCOS, polycystic ovary syndrome, is a big one.
Huge. Characterized by anovulation, irregular or no periods, hirsutism, excess hair growth, and often associated with increased BMI.
And the mechanism behind the anovulation.
Often linked to insulin resistance. This messes with GnRH pulsation in the brain, leading to that classic high LH to FSH ratio.
And the hirsutism.
That relatively higher LH stimulates the Keton-Turner cells in the ovary to churn out more androgens.
Right, because LH stimulates the Athia cells and Leydig cells to make androgens.
Exactly. While FSH stimulates granulosa and Sertoli cells, promoting aromatase activity to convert those androgens to estrogen and priming follicles. That balance is off in PCOS.
So, treatment for PCOS, what's first line?
If BMI is high, weight loss is often the first recommendation. It can really improve insulin sensitivity and hormone levels.
And then, if not trying to conceive.
OCP's oral contraceptive pills are common. They regulate cycles, reduce androgens.
And if pregnancy is the goal.
Then ovulation induction agents like clomiphene are often used.
What are the long-term risks associated with PCOS?
Two major ones highlighted. Endometrial cancer, due to the chronic unopposed estrogen from an ovulation.
Yeah.
Type 2 diabetes mellitus, because of that underlying insulin resistance.
The review also mentions that type 2 diabetes can sometimes mimic PCOS symptoms, right?
It can. Anovulation, hirsutism, high BMI, acanthocytes nigricans, those dark skin patches, but typically without other features of Cushing's syndrome.
Okay. What about premature ovarian failure or primary ovarian insufficiency?
That presents with menopause symptoms like hot flashes, vasomotor symptoms, but in younger women, along with high FSH levels.
Can it be autoimmune?
Yes, autoimmune ovarian failure is a cause, and you might see it alongside other autoimmune conditions like Hashimoto's thyroiditis.
Speaking of thyroid, how does it change in pregnancy?
Well, TSH-T3 and free T4 usually stay normal, but total T4 often goes up
Why is that?
because pregnancy increases thyroid-binding globulin levels. So more T4 is bound up, but the active free T4 level is generally stable. That's why you check free T4 in pregnancy, not total T4.
And TSH is still the go-to for screening outside of pregnancy.
Correct. Also, women with Hashimoto's on levothyroxine often need a dose increase during pregnancy.
Got it. What about treating hyperthyroidism in pregnancy? Those thionamides, PTU, and methimazole.
Right. General approach. PTU is often preferred in the first trimester because methimazole has a small teratogenic risk.
But then
Often switch to methimazole for the second and third trimesters because PTU carries a risk of liver toxicity.
And for thyroid storm in pregnancy?
PTU is a choice there.
Okay. What about postpartum thyroiditis?
That's a transient thing. Often starts with a hypothyroid phase, then swings hypoloco. Diagnosed with TSH. Increases future risk of Hashimoto's. Treatment is symptomatic.
And preventing cretinism in newborns.
Routine newborn screening is absolutely critical for that.
Okay. Moving away from hormones slightly, chronic interstitial cystitis.
Presents with anterior vaginal wall pain, dysuria, but the urinalysis is normal. Treatment is mostly supportive. Avoid steroids.
And appendicitis in pregnancy can present high up.
Yeah, upper right quadrant sometimes. Treatment is laparoscopic appendectomy.
Beta HCG levels, again, molar pregnancy versus ectopic.
Very high levels suggest a mole.
Yeah.
Low, slow rising levels are more typical of an ectopic.
And choriocarcinoma mets.
Often go to the lungs. Brain mets can happen too, sometimes mimicking a stroke, especially with super high beta HCG.
Ectopic pregnancy definition and common site.
Pregnancy outside the uterine cavity. Most common location is the ampulla of the fallopian tube.
Most common cause.
History of PID, pelvic inflammatory disease leading to tubal scarring.
Treatment options.
Laparoscopic removal, either salpingostomy, saving the tube, or salpingectomy, removing the tube, or methotrexate medically if specific criteria are met.
What are those criteria, roughly?
Stable vitals, beta HCG usually under 6,000, size under 3 centimeter, no fetal heart rate, no significant pelvic fluid.
Okay. PID itself causes and treatment.
Usually chlamydia and/or gonorrhea, outpatient, IM ceftriaxone plus oral azithromycin or doxycycline. Inpatient fight the antibiotics if septic.
What if fever persists despite antibiotics?
Get an adnexal ultrasound to look for a tubo-ovarian abscess. If present, it needs drainage.
All right, let's quickly run through the types of spontaneous abortion mentioned. Inevitable.
Bleeding plus an open cervix. Usually needs vacuum aspiration.
Rend.
Bleeding, but cervix is closed. Bed rest might be advised. Potential to continue.
Incomplete.
Bleeding, passage of clots, but some pregnancy tissue still inside. Needs management to complete evacuation.
Complete.
History of bleeding cramping, but ultrasound shows an empty uterus. Follow-up.
Miss.
Fetal demise occurred, but no tissue has passed. Needs intervention.
Septic.
Fever, discharge, pain, often history of attempted termination. Treat the infection aggressively, then evacuate the uterus.
And confirming a completed spontaneous abortion.
Serial beta HCG measurements until they're negative.
Okay. Uterine fibroids leiomyomata. Different types.
Submucosal or under the lining cause bleeding, large smooth uterus. Subserosal or on the outside globular uterus, usually no bleeding. Pedunculated submucosal can hang down on a stalk, sometimes present as a vaginal mass.
Asymptomatic fibroids.
Usually just observation.
Symptomatic.
Anesthesides, OCPs, other medical or surgical options.
What about adenomyosis?
That's endometrium growing into the uterine muscle wall. Causes dysmenorrhea, menorrhagia. Uterus is diffusely enlarged and smooth on ultrasound, no discrete masses.
Treatment similar to fibroids.
Yeah, anesthesides, OCPs, leuprolide. Definitive treatment is hysterectomy.
Okay. Carpal tunnel in pregnancy.
Common. Bilateral thumb abduction weakness can happen. Usually resolves postpartum.
Chorioamnionitis.
Infection of membranes fluid. Often after prolonged rupture of membranes, like 18 hours. Presents with abdominal pain, fever. Treat with ampicillin, gentamicin, clindamycin because it's polymicrobial.
And postpartum endometritis. Infection after delivery.
Fever, abdominal pain, often after C-section. Same antibiotic coverage needed. Ampgen Clinda.
Puerperal sepsis.
That's postpartum endometritis plus signs of sepsis like low blood pressure.
Arthrolan glands cyst or abscess.
Lump at 4 or 8 o'clock on the vulva. Yeah. Cyst, warm compresses. Abscess. Needs drainage, also polymicrobial. Serious complication, though rare, is necrotizing fasciitis.
Lichen sclerosis.
Gray whitish, patchy, sometimes rough skin on vulvar perineum. Itchy. Needs a punch biopsy to rule out squamous cell carcinoma. Treat LS itself with topical steroids.
And main risk factor for perineal SCC in diabetics?
HPV infection, not the diabetes itself.
Ruptured ovarian cyst presentation.
Sharp adnexal pain, maybe no mass felt, often serosanguinous fluid in the cul-de-sac on ultrasound.
Yeah.
Usually supportive treatment.
Ovarian torsion.
History often includes a cyst. Pain starts colicky, becomes constant. Palpable adnexal mass. Surgical emergency laparoscopic detortion.
Hemorrhagic corpus luteum cyst.
Might present mid-cycle as a mobile, slightly tender adnexal mass, maybe around 5 centimeters.
Toxic shock syndrome.
Linked to tampon use. Diffuse rash, hypotension. Caused by Staph aureus toxins.
Spotting after intercourse during pregnancy, normal ultrasound.
Likely minor cervical trauma.
Kidney stones in pregnancy. Urolithiasis.
Can cause severe flank pain, maybe faintness with urination. Progesterone slows ureteral peristalsis, increasing risk.
Gallstones also more common.
Yes. Progesterone slows gallbladder emptying and estrogen increases cholesterol synthesis.
Recurrent first trimester miscarriages in someone with only one kidney.
Should raise suspicion for congenital uterine abnormalities.
Simple 5-centimeter ovarian cyst, negative beta HCG, dull pelvic pain.
Often managed with OCPs and a repeat exam in 6 weeks to see if it resolves.
Primary dysmenorrhea. Extremely painful periods, normal exam.
Caused by prostaglandin, PGF2 excess. Treat with NSAIDs.
Endometriosis. Painful periods plus.
Nodularity of the uterosacral ligaments is a classic sign mentioned. Diagnosis is via diagnostic laparoscopy.
Dermoid cyst. Mature cystic teratoma.
Pelvic pain and ultrasound shows a cystic mass, often with calcifications.
Ovarian cancer appearance on imaging.
Often described as multiple masses caked on the omentum.
Seizures in pregnancy with epilepsy. Medication adjustments.
May need to increase phenytoin dose to maintain levels. No. Definitely stop valproic acid if planning pregnancy due to neural tube defect risk.
Okay, types of incontinence. Stress incontinence.
Leakage with cough sneeze. Due to downward movement of vesicourethral junction, decreased urethral tone. Treat with Kegels or mid-urethral sling surgery.
Urge incontinence.
Sudden urge, gotta rush. Hyperactive detrusor muscle. Can be linked to MS or perimenopause, estrogen deficiency. Treat with oxybutynin or mirabegron.
Overflow incontinence.
High post-void residual volume. Seen in diabetes, neurogenic bladder, or BPH, outlet obstruction. Treat diabetic overflow with bethanical.
Hormone replacement therapy, HRT. Main indication. risks.
Only really approved for severe vasomotor symptoms, hot flashes. Increases risk of breast cancer if estrogen included. VT stroke. Not for bone density preservation primarily. Estrogen only if no uterus.
Atrophic vaginitis.
Postmenopausal symptoms, blood stains, painful intercourse. Mucosa looks thin, friable due to low estrogen. Treat with lubricants or topical estrogen.
Similar symptoms in breastfeeding.
Yes, due to high prolactin causing low estrogen. Recommend lubricants.
Postmenopausal bleeding on HRT, especially if progestin stopped.
Needs an endometrial biopsy.
New breast cyst in someone on HRT. Prior normal mammogram.
FNA biopsy is the next step.
Combined OCPs and cancer risk.
Decrease ovarian and endometrial cancer risk. May slightly increase breast cancer risk, increase cervical cancer risk, possibly due to less barrier use, more HPV exposure.
So for a teen with an aunt who had ovarian cancer, no BRCA known.
No routine screening needed, but offer OCP info.
BRCA mutation carrier with strong family history of GYN cancers.
Consider risk-reducing surgery, total hysterectomy and bilateral salpingo-oophorectomy, BSO.
Pap smears after hysterectomy. Benign reasons versus CIN3.
No longer needed if hysterectomy was for benign reasons. If for CIN3, continue annually.
General Pap guidelines.
Start at 21, every 3 years. Or every 5 years with HPV co-testing after 30. Stop at 65 if prior screens normal and no high-grade history. HIV positive at diagnosis, then annually.
Managing abnormal PAPs quickly, ASCUS.
Repeat cytology or HPV test.
LSIO.
Repeat co-testing in a year, or colposcopy.
HSIO.
LEAP or colposcopy plus biopsy.
AGC.
Endometrial biopsy if colposcopy is normal.
CIN on biopsy. CINI.
LEAP or close surveillance. Colpocytology Q6 months.
OSS.
LEAP aiming for clear margins, then post-op testing.
Cone biopsy needed when?
Often for LSLL if the squamocolumbidar junction isn't fully seen on colposcopy.
Okay, switching back to obstetric emergencies, amniotic fluid embolism.
Sudden shortness of breath, tachycardia, bleeding from IV sites after placental separation. Supportive care is key.
Pulmonary embolism postpartum.
Shortness of breath, tachycardia. Start heparin, then spiral CT if not pregnant, or VQ scan if pregnant.
Atelectasis postpartum.
Fever. Decreased breath sounds, usually within 2 days of C-section. Urine culture, negative.
Vasa previa.
Painless third trimester bleeding, often with rupture of membranes, then fetal bradycardia. Fetal vessels are crossing the os unprotected, associated with velamentous cord insertion or sexcentriate lobe.
Sheehan syndrome.
Postpartum hemorrhage needing transfusion, followed by symptoms of panhypopituitarism, weight loss, cold intolerance, can't breastfeed, pituitary necrosis.
Hematometer versus hematocompulpos.
Blood collection in uterus.
Yeah.
Hematometer can cause low BP via vagal response versus vagina. Hematocompulpos normal BP, often due to imperforate hymen. Treat with incision.
DVT postpartum.
Calf pain, maybe positive Homan sign, pain with dorsiflexion. Diagnosed with duplex ultrasound.
Down syndrome screening markers. First trimester.
Low PPPA, high beta HCG, increased neutral translucency, absent thicoplastic nasal bun.
Second trimester quad screen.
Low AFP, high beta HCG, low estriol, high inhibin A.
Cell-free DNA.
Can be done from 10 weeks, highly sensitive. Note, all markers tend to be low in Edwards syndrome, trisomy 18.
Most common reason for an abnormal AFP level.
Dating error. Next step is repeat ultrasound for accurate dating.
Pelvic organ prolapse types, SELAs.
Cystocele, bladder anterior superior. Urethrocoele, urethra anterior inferior. Enterocele, small bowel posterior superior, may feel movement. Recticella, rectum posterior inferior.
Urethral prolapse versus stress incontinence.
Prolapse is protrusion of distal urethra. Stress incontinence is leakage with Valsalva. Downward mobility of bladder neck. Different things.
Cervical incompetence insufficiency.
Painless dilation. Short cervix. Funneling on ultrasound. History of conicization or second try loss are risk factors. Treat with cerclage. Risk of cord prolapse if breached during labor.
Labor definitions. Protracted latent phase, arrest of active phase.
Standard definitions exist based on duration and lack of progress.
Cephalopelvic disproportion,
Yeah.
CPD.
Fully dilated, strong contractions, but baby's head won't descend through the
A
pelvis.
child with foul discharge spotting foreign body versus abuse.
Look for signs of trauma, lacerations, to suggest abuse. Foreign body is more common otherwise.
Sexual assault signs in elderly with altered mental status.
Vaginal laceration, perineal redness swelling should raise high suspicion.
Preventing recurrent UTIs.
Voiding after coitus helps. Postcoital prophylaxis with TMP-SMX if truly recurrent and previously treated successfully.
UTI symptoms not improving with antibiotics.
Consider urethral culture for chlamydia.
Metallic taste after epidural.
Likely intravascular injection of the anesthetic.
Postpartum mood disorders. Blues versus depression versus psychosis.
Blues, Mild, transient, 7–10 days. Depression, persistent 2 weeks. Insomnia, irritability needs SSRI-CBT, immediate psych evil. Psychosis, mania, delusions, hallucinations, immediate psych evil, emergent.
Oligohydramnios at 42 weeks, unfavorable cervix.
Administer prostaglandin for cervical ripening. Amnioinfusion is for variable D cells with ruptured membranes.
Microcytic anemia in pregnancy not responding to iron.
Think thalassemia, diagnosed with hemoglobin electrophoresis, will show elevated HbA2. Iron deficiency in pregnancy in African American usually shows 95% HbA1.
Physiologic anemia of pregnancy, gestational thrombocytopenia.
Normal HB drop to around 10.5 is physiologic.
Yeah.
Platelets 150,000 is gestational thrombocytopenia. ITP can cause fetal platelet issues too.
Shoulder dystocia complications.
Duchenne palsy, C5-C6 nerve injury.
Right.
Clavicular fracture can happen even with McRoberts maneuver. Vaginal laceration, especially diabetic mom. Bleeding despite firm uterus after McRoberts.
Uterine atony, most common cause of PPH.
Yes. Treat with massage, oxytocin. Ergonovine is an option, but avoid in hypertension.
Uterine inversion.
Heavy bleeding, low HRBP, unresponsive to fluids, can't feel uterus abdominally. Rare emergency.
Episiotomy cut too far back.
Can damage the external anal sphincter.
Uterine rupture signs.
Constant sharp abdominal pain, fetal late D cells, abnormal fetal parts high. Risk factors, prior C-section, oxytocin hyperstimulation.
Leopold maneuvers just confirm fetal position via abdominal palpation, right?
Right.
Granulosa cell tumor again.
Ovarian mass causing postmenopausal bleeding due to estrogen production.
Yeah.
Can lead to endometrial hyperplasia cancer.
Irregular periods in perimenopause with proliferative endometrium.
Cyclic progestin therapy can help regulate and protect the endometrium.
How do OCPs improve bleeding?
By synchronizing the endometrium, creating predictable withdrawal bleeds.
Rh-negative mom, third pregnancy, had ROGEM before.
Still need to check her indirect Coombs test for Rh antibodies this pregnancy.
ABO incompatibility in newborn.
Usually O+ mom, A or B baby. Can cause pathologic jaundice.
Rh incompatibility.
Rh-negative mom, Rh-positive baby, usually sensitized from prior pregnancy, can cause fetal hydrops.
When to give ROGEM standard times?
Around 28 weeks. Postpartum if baby is Rh-positive. After abortions, ectopic procedures, trauma.
Positive Coombs for anti-KEL.
Check father's KEL type. KEL antibodies can cause fetal issues.
Abruptio placenta versus placenta previa.
Abruption. Painful third trimester bleeding. Risk factors, MVA, cocaine, previa. Painless third trimester bleeding.
Placenta acrotin crita percreta.
Abnormal placental attachment invasion. Major cause of postpartum hemorrhage needing intervention.
Vaginal infections recap. Candidiasis yeast.
Itching, redness. Classic discharge is thick white, but can be normal. See used on KOAC mount. Treat with antifungals, topical nystatin, oral sulconazole, or more resistant in diabetics.
Chlamydia.
Mucopurulent discharge, often no organism seen on basic wet mount. Treat with azithromycin or doxycycline.
Gonorrhea.
Mucopurulent discharge. See gram-negative diplocacci. Treat with IM, ceftriaxone, acifixine, PLUS, azithromycin for chlamydia cover.
Trichomoniasis.
Strawberry cervix, erythematous. Yellow-green discharge. See modal flagellates on wet mount. Treat patient AND, partner with metronidazole.
Bacterial vaginosis, BV.
Thin gray watery discharge, fishy odor, positive whiff test. Clue cells on wet mount. Treat with metronidazole, often topical first.
Positive VDRL screening test, no symptoms.
Confirm with FDA-ABS for syphilis. If initial RPR VDRL negative but suspicious painless ulcer, repeat RPR later, might be early primary.
Condylomata acuminata.
Genital warts, HPV 611. Crusty, painless papules, often posterior fourchette. Treat with podophyllum resin, etc. Gardasil protects against 6, 11, 16, 18. Painful ulcer, crater, caused by Haemophilus ducreyi, gram-neg red rods. Treat with azithromycin.
VZV chickenpox exposure in non-immune pregnant woman.
Give VZV-IVG within 96 hours. Also give VZV-IVG to neonate if mom develops lesions 5 days before to 2 days after delivery.
Congenital rubella syndrome, hallmark.
PDA in neonate. Mom might have had arthritis during pregnancy, not necessarily a rash.
Parvovirus B19 in pregnancy.
Maternal fever rash. Risk of fetal hydrops.
Herpes in pregnancy outbreak versus prevention.
Oral acyclovir for active painful vesicles. Prophylactic acyclovir near term to reduce lesions at delivery. C-section if active lesions or prodrome during labor.
HIV in pregnancy, most important prevention step.
Mom taking heart is key for reducing vertical transmission, more crucial than avoiding breastfeeding, where formula is safe. Zidovudine often given pre-C-section and to neonate.
Hepatitis B positive mom, newborn management.
HBIG plus Hep B vaccine within 12 hours. If mom negative, just vaccine. If status unknown, vaccine within 12 hours and HPIG within 7 days if mom tests positive. Vaccinate non-immune pregnant women.
Flu shot in pregnancy. MMR-TB treatment.
Flu shot, I am killed, is safe and recommended.
Yep.
MMR live is contraindicated. Treat active TB with RAPE, then RII for 9 months total.
Breastfeeding and OCPs.
Estrogen can decrease milk supply protein. Avoid combined OCPs 6 weeks postpartum. Progestin-only methods preferred.
Androgen insensitivity syndrome, AIS, versus mullerianogenesis. Phenotypically female, blind vaginal pouch.
Key difference is hair. AIS 46XY has sparse absent pubic axillary hair. Mullerianogenesis 46XX has normal hair.
5-alpha reductase deficiency.
46XY, ambiguous genitalia at birth, virilization, hair growth, acne, etc. at puberty.
Turner syndrome.
45XO. Amenorrhea, high FSH, no breasts, scant pubic hair, short stature, normal bone age usually.
Normal findings post C-section day 2.
Slightly red incision, tender abdomen, maybe palpable groin nodes are all possible and not necessarily concerning.
Cervical SCC presentation.
Vaginal bleeding can cause hydroreader if it impinges the ureter.
OCP contraindications, key ones.
Smoker 35, migraine with aura, severe HTN 160-100, history of VTE, thrombotic disorder, stroke IHD history, current breast cancer liver tumor. Cyclic progesterone therapy can just mean OCPs for irregular cycles.
Most effective emergency contraception, second best.
Copper IUD is number 1. Ulipristal pill is second best.
Copper IUD, okay with enlarged uterus fibroid.
Generally, yes, if fibroid isn't distorting cavity significantly. Counsel about potentially heavier menses.
Depot injection versus Nexplanon implant.
Depot progestin injection Q3 months, decreased bone density risk mentioned, maybe lower breast cancer risk. Our Nexplanon progestin implant 3 years, common side effect is erratic bleeding.
IUD contraindications.
Active stipid or recent history 3 months, current pregnancy, gynecologic malignancy.
Good contraceptive for HTN patient with poor pill adherence. For patient who forgets pills, recent chlamydia treatment.
Levonorgestrel IUD, good for the HTN adherence issue. Depot might be good for the forgets pills recent STI patient. No pelvic insertion needed.
Breast cancer history with new bilateral leg paresthesias.
Worry about spinal mets. Give steroids first, then get an MRI.
Prior large baby, macrosomia. Risk in current pregnancy.
Increased risk for gestational diabetes. Screen with OGTT at 24-28 weeks.
Gestational diabetes management. Fetal hyperinsulinemia effect.
Insulin often preferred.
Yeah.
Fetal hyperinsulinemia inhibits surfactant production, increasing risk of NRDS.
Steroids for fetal lung maturity timing. Magnesium.
2 doses 24 hours apart if delivery expected 34 weeks. Single course considered 34-07, 36-67 weeks in some cases. Add magnesium for neuroprotection if 32 weeks.
Tocolytics purpose and contraindications.
Use 34 weeks to delay delivery, allow steroids to work, tributylene, mifetamine, etc. Contraindicated with infection, significant IUGR, dilation 4 centimeters generally.
Braxton Hicks.
Normal. Irregular, usually painless contractions in 3rd trimester.
GBS prophylaxis when and how.
IV penicillin or ampicillin during labor if indicated. Positive culture, prior GBS baby, unknown status in preterm labor, etc. Needs to be given 4 hours before delivery, ideally, not oral augmentin.
Bishop score. Fetal fibronectin. PP-ROM.
Bishop score assesses cervical readiness for induction. Fetal fibronectin helps predict preterm labor risk if symptomatic 22-35 weeks. PPROM is rupture of membranes, 37 weeks, diagnosed via sterile speculum exam. Pooling, ferning, nitrazine.
Wow. We have definitely covered a huge amount of ground there. A real deep dive into those key OBGYN points from the review material.
Yeah, a lot of high-yield associations and distinctions.
Hopefully breaking it down like this has made it, clearer and more digestible for you listening, going beyond just memorizing facts to understanding the why sometimes.
But it's important to remember this is really just scratching the surface, isn't it?
Absolutely. Each of these topics could be a whole discussion on its own. We've hit the highlights based on this specific source. So the question back to you is, what still lingers? What connections did you make? Or what areas sparked more curiosity for you? We really hope you'll take these points and maybe explore further into the topics that resonated most.
Keep learning, keep questioning.
Exactly. Well, thank you for joining us on this deep dive. We're definitely looking forward to exploring new topics with you again soon.